Good morning, everyone. I'm Ken Kalunian from the University of California, San Diego, and today we're going to be speaking about integrating patient-centered approaches to rheumatoid arthritis management. These are my disclosures. So first of all, I've some housekeeping issues, program information. So this is approved for 1 CME credit. It's provided by the North American Center for Continuing Medical Education, supported by an educational grant from Gilead Sciences. And if you have any questions, please type it in on the right sidebar and I'll answer them at the end of my presentation. So today we have 3 learning objectives. The first is to identify the challenges with traditional DMARD therapy and biologic treatments in terms of response, resistance, and tolerability. Secondly, we're going to evaluate the role of JAK inhibitors within the RA treatment armamentarium. And lastly, we're going to leverage JAK inhibitors for patient-centric approaches to RA management. What we're going to be talking today is all based on the concept of treat to target. And what is that? Well, it's the goal of reducing disease activity to very low levels or remission. And it's a realistic goal. And there's emerging evidence suggesting that treating to achieve these targets enhances long-term structural and quality of life outcomes. Treat to target has become an attractive concept in clinical management that is generally defined as a treatment strategy in which the clinician treats the patient aggressively enough to reach and maintain specified and sequentially measured goals such as remission or low disease activity. These approaches in clinical trials have informed clinicians that there are significant benefits of early aggressive treatment approaches. Last year, you and all published what I thought was a very interesting paper that showed that there were certain predictors of remission in clinical trials that utilized the treat to target strategy. Those included young age, male gender, lower total joint counts, baseline activity scores measured by the DAS28, educational attainment, shorter disease duration and shorter time to remission, use of combined DMARDs, reduction in the MHAC, which we'll speak about a little bit later, and fewer previous DMARDs, as well as the use of biologic DMARDs. You had all went on to characterize the studies that were associated with sustained remission and their corresponding predictors. So these corresponding predictors were that if you had DAS28 scores less than 2.6 in the last 2 consecutive visits, at least 3 marks apart, that was a good predictor, as well as having at least 2 consecutive visits with no treatment changes, or satisfaction of any definition for greater than or equal to 6 months or on 2 or more consecutive visits. And lastly, also remission at 2 consecutive visits, at least 1 month apart, corresponded to a good predictor. In 2015, the American College of Rheumatology developed a treatment algorithm for established rheumatoid arthritis. They started with the concept that in conventional synthetic DMARD naive patients, we should start with that type of therapy as monotherapy. And if after a certain period of time, the patient didn't respond to that, whereas they had maintenance of moderate to high disease activity, then the conventional synthetic DMARD could be combined with another conventional synthetic or combined with a TNF inhibitor, with or without methotrexate, or a non-TNF biologic with or without methotrexate, or tofacitinib with or without methotrexate. Now, at this time, 2015, tofacitinib was the only JAK inhibitor available, which is why they specified tofacitinib. If after one of those strategies, there was a continuation of moderate to high disease activity, then their idea was that you would take a TNF inhibitor and combine it with methotrexate as either the first or second biologic, or a non-TNF biologic with or without methotrexate, or tofacitinib with or without methotrexate. So kind of shift things around, try something else that was in the prior box. The ACR has just finished, actually, and is about to publish their updated 2020 guidelines for RA management. And these guidelines were developed as a graft guideline manuscript based on the need related to the availability of more treatment options and more information about existing therapies. And the guidelines were really based on the goal to improve quality of life by reducing symptoms, reducing functional limitations, preventing joint damage, and decreasing complications of the disease. The treatment guidelines were based on the concept to develop recommendations for the use of DMARDs, including conventional, targeted biologic, and targeted synthetic DMARDs, as well as for recommendations for the use of corticosteroid therapies. And they also intended to clarify differences in treatment recommendations for patients who were DMARD naive versus those who had already been treated with one or more DMARDs. They also wanted to clarify differences in treatment recommendations for patients with low versus moderate to high disease activity, and develop recommendations for tapering DMARDs once you had remission. They wanted to also include recommendations for non-pharmacological therapies. They wanted to include recommendations related to comorbid conditions such as congestive heart failure, hepatitis B or C, cancer, the history of serious infections. And they also wanted to include recommendations for vaccine administration. The EULAR organization this year also presented RA treatment guidelines at their meetings during the summer. And their concept was based on the fact that DMARDs should be started as soon as the diagnosis of RA is made. And therapy should be aimed at reaching a target of sustained remission or low disease activity. They thought that monitoring should be frequent in active disease, meaning every 1 to 3 months. And if no improvement was achieved by 3 months or the target hadn't been reached by 6 months, then therapy should be adjusted. They thought that methotrexate should be part of the first treatment strategy. And in patients with a contraindication to methotrexate, or in patients who had early intolerance to methotrexate, luflitamide or sulfasalazine should be considered as part of the initial treatment strategy. We thought that short-term corticosteroids should be considered when initiating or changing conventional synthetic DMARDs in different dose regimens and routes, but should be tapered as rapidly as clinically feasible. They felt that if a target wasn't achieved by the first conventional synthetic DMARD, or when poor prognostic factors were present, a biologic or targeted synthetic DMARD should be added. They thought the biologic and targeted synthetic DMARDs should be combined with a conventional DMARD. In patients who can't use a conventional synthetic DMARDs, IL-6 inhibitors or targeted synthetic DMARDs could be an alternative to consider. If a biologic or targeted synthetic DMARD failed, another biologic or targeted synthetic DMARD should be considered. If one TNF inhibitor failed, patients, they thought, should receive an agent with another mode of action or a second TNF inhibitor. And if a patient was in persistent remission after having tapered corticosteroids, then the patient should be considered for the ability to taper biologic or targeted synthetic DMARDs, especially if the patient is treated with conventional synthetic DMARD. And if the patient is in persistent remission, tapering the conventional synthetic DMARD should then also be considered. This slide is actually not meant to have me go over it. It's just really a recap of what I just said. And I've included it here just in case you wanted to take a snapshot of it to kind of keep what I said in mind. What I said was a handful. So there you go. Go ahead and click away if you need to or want to. And I'll give you a second to do that. Okay. So as part of the 2020 ACR recommendations, last year they published actually a prelude to it where they recommended patient-reported functional status assessments and their utility in rheumatoid arthritis. And basically what they did was they based these recommendations after looking at almost 12,000 articles of which 56 were included in their review. These are descriptions of measures, properties, study quality, level of evidence, and feasibility, all abstracted and scored. And following a modified Delphi process, 7 measures fulfilled minimum standard for regular use in most clinical settings, and 3 were recommended, all with half the number of questions compared to prior versions, and all not requiring computer usage. So it was a little more user-friendly for the patients. And these consisted of the PROMIS physical function 10-item short form, the HAC-11, and the multidimensional HAC. And here's the reference in case you want to take a look at them in more detail. So what's a current treatment paradigm? And this was based on Ron van Vollenhoven's Lancet article in 2009, Jaz Singh's article in Arthritis Care and Research in 2016, and Joseph Smolin's article in Annals of Rheumatic Diseases in 2017. Start with methotrexate. And approximately 30% of patients achieve low disease activity with methotrexate monotherapy. Decision-making is necessary for the next step, but it's not firmly established for what that really is in methotrexate inadequate responders. Therapeutic decisions are often based on comorbidities and contraindications, and unfortunately, predictive response biomarkers aren't yet available. The ACR and EULAR recommendations suggest a biologic or targeted synthetic DMARDs as possible second-line options. There's a lot of diversity in rheumatoid arthritis pathophysiology, and that's why the treatment really needs to be considered in light of who the patient is to optimize treatment responses. There are genetic, epigenetic, and environmental factors that vary by patient. Individual patients have differing predominant disease-driving cell populations, cytokines, and signaling pathways leading to articular and systemic manifestations. And while many conventional synthetic, biologic, and targeted synthetic DMARDs are effective, responses vary from patient to patient. There are challenges with traditional and biologic DMARDs. First of all, response resistance and tolerability vary widely in the heterogeneous population of RA patients. Poor prognostic factors, such as the presence of autoantibodies and joint erosion, confer the need for more aggressive therapy with a more rapid onset. Comorbidities, extra-articular manifestations, pregnancy, or pregnancy planning may confer extra caution or needs beyond traditional or biologic agents. Environmental factors such as diet and cigarette smoking may affect disease susceptibility, interfere with inflammatory pathways, and inflammatory responses. Alcohol use limits the ability to use methotrexate. Hepatitis and other infections interfere with drug selection. Obesity associates with poor TNF inhibitor response, and cost reimbursement is ever so challenging. This slide is complicated, but is really meant to show you that at the molecular or synovial perspective, there are several signal transduction pathways that are operative in rheumatoid arthritis, including the MAP signaling cascade, the SYK and BTK signaling cascade, and the JAK signaling cascade, among others. And today we're going to be focusing on the JAK signaling cascade. So let's focus in on that. So we know that cytokines signal through a combination of JAKs and STATs. There are 4 known JAKs, 1, 2, 3, and TYK2. These are non-receptor protein tyrosine kinases that are active after binding of various cytokines to their receptors. There are 7 known STATs, 1, 2, 3, 4, 5A, 5B, and 6. And these are proteins acting as latent cytoplasmic transcription factors. Phosphorylation at active type 1 or type 2 cytokine receptor complexes activates specific STAT subsets. There is cytokine-specific control of gene expression, and with signaling, there is a complex set of interactions between inflammatory and cellular metabolic functions that result in a complex interplay, resulting in inflammation and disease mechanistic pathogenesis. This slide is meant to show you the different cytokine receptors. So there are type 1 cytokine receptors and type 2 cytokine receptors. And type 1 receptors lead to lymphocyte proliferation and homeostasis, T cell differentiation and inflammation, and erythropoiesis, myelopoiesis, and platelet production. Whereas the type 2 cytokine receptors are important for innate antiviral defense. The type 1 cytokine receptors work through IL-2, 4, 7, 9, 15, and 21, IL-6 and GM-CSF and erythropoietin, whereas the type 2 cytokine receptors work through primarily the interferon pathways. So here's what happened here's what happens with JAK inhibitors. JAK inhibitors target these intracellular cytokine signaling through the JAK pathway. So first of all, over on the left, you'll see the cytokines bind to type 1 and type 2 cell surface receptors. Then JAK inhibitors, when given, block ATP binding to JAKs and inhibit phosphorylation and activation of JAKs. And JAKs, therefore, can't phosphorylate the cytokine receptors. Statins, therefore, can't dock and are not phosphorylated or activated. And gene transcription and cytokine production is partially inhibited, and gene production and cytokine production is therefore reduced. All right, so what are these JAK inhibitors? Well, in the US, we currently have 3 that are approved and 1 that's under review. Tofacitinib, that was the first approved, and that's primarily a JAK3, JAK1 inhibitor, more than JAK2. And that's approved at 5 milligrams twice a day. And this is these are all oral drugs. Baricitinib is primarily a JAK1, but also has some JAK2 inhibition, and it was approved by the FDA at 2 milligrams a day. These are both approved for RA. As well as others now, but we'll focus on RA today. Upadacitinib is much more of a JAK1 specific inhibitor, but has just a little bit of JAK3 inhibition, and is approved at 15 milligrams a day. And Filgotinib's under review, and it, like Upadacitinib, is a relatively JAK1 specific inhibitor, but instead of having some JAK3 like Upa does, it has some JAK2 inhibition. And we'll talk about these in more detail. But just one point to point out, selectivity is really desirable in order to avoid off-target side effects. All right, this slide is complicated, but what I've tried to point out here is the responses of JAK inhibition by the different types of JAK inhibitors versus methotrexate inadequate responders. So these are all studies of patients who are methotrexate inadequate responders who were thereby randomized in randomized controlled trial looking at methotrexate plus placebo versus methotrexate plus the specific JAK inhibitors. And in study 1, this is looking at methotrexate plus placebo versus tofacitinib plus methotrexate. Study B is methotrexate plus placebo versus baricitinib plus methotrexate. Study C is methotrexate versus upadacitinib, and study D is methotrexate versus filgotinib. And what you can see here, looking at ACR responses, is that basically there's some significant improvements versus the combination of the JAK inhibitors plus methotrexate. And most of that difference is really significant differences. Most of those are seen in ACR 50 and 70 responses, which is really fairly significant, right? But the bottom line is there's really overall at least non-inferiority. So the combination is mostly, especially in the ACR 50 and 70 range, better than methotrexate alone and methotrexate inadequate responders. And that's all across the board and pretty significant and really encouraging. These are looking at the same studies, looking at DAS28 ESR responses, so looking at outcome from a different perspective. And you can see that you're seeing significant differences here across the board among all the different JAK inhibitors. And the last slide in this series looks at structural response, and you can see that the combination therapy is much better than methotrexate alone. So these are all remarkable findings and really are across the board. There's some suggestion here that inhibiting JAK1 specifically, like you do with study C and D, Upadacitinib and Filgotinib, there's better structural responses, but it's really across the board. This slide is looking at kind of understanding what class of drugs is really best for methotrexate inadequate responders. And what we're doing here is looking at a series of studies that look at methotrexate inadequate responders who are then given adalimumab, which is a TNF inhibitor, of course, versus the different JAK inhibitors. So the first slide is adalimumab versus tofacitinib. Second is adalimumab versus Bari, adalimumab versus Upa, and adalimumab versus Filgotinib at 2 different doses. And what you can see here is that there are similar responses across the board. So there's non-inferiority. The JAK inhibitors aren't superior, it doesn't appear, except in some instances here, especially in the JAK1 specific inhibitors, Upa and Filgotinib, at ACR 50 and 70 responses, but generally it's non-inferiority. You can use either one, it looks like, from these studies. That was using the ACR 20, 50, and 70. This is looking at the DAS28 CRP responses among the different JAK inhibitors versus adalimumab. And you can see that for the relatively JAK non-specific inhibitors at week 24, there's non-equivalence, or there's no difference, so there's non-inferiority. And for the JAK-specific inhibitors at 12 weeks, it looks like the JAK1 specific, relatively specific inhibitors are superior with DAS28 to adalimumab. This study looked at whether TOFA monotherapy or TOFA plus methotrexate was associated with quality of life quality of life outcomes. And it looked like combination and mono-retention curves weren't statistically different. So from that perspective, patient perspectives don't really notice a difference, but using the validated outcome instruments and when you do see a response and structural response, it looks like it also is non-inferiority. There's non-inferiority. Okay, now this is a study looking at TOFA monotherapy, TOFA plus methotrexate, and adalimumab and methotrexate in methotrexate inadequate responders. So it was meant to answer the question, in methotrexate inadequate responders, should we give TOFA alone, TOFA and methotrexate, or adalimumab and methotrexate? What you see here is looking at ACR 20 and ACR 50, the responses were quite similar with time out to 12 months. The TOFA monotherapy didn't respond quite as well as tofacitinib and methotrexate or adalimumab plus methotrexate, but they were all fairly similar. This looks at the study looks at upadacitinib versus abatacept. So looking at a different option for methotrexate inadequate responders. And these data are for week 12 and week 24. And these were in patients with prior inadequate response or intolerance to a biologic DMARD. So this is not just methotrexate inadequate responders, but it's methotrexate inadequate responders plus an initial intolerance to a one biologic DMARD. And it's mostly TNF inhibitors, right? Because that's really what most people start with. And you can see that there was basically non-inferiority between the different groups. So the bottom line was that UPA and abatacept respond very, very well in in those patients who had inadequate response or intolerance to biologic DMARDs. This study is looking at filgotinib in patients with inadequate response to methotrexate. And what you see here is it's actually looking at filgotinib at 2 different doses and adalimumab versus methotrexate alone using placebo. And you can see that the gray line, the gray bars, the gray line actually is the methotrexate group. And that group did not respond as well as either of the dosages of filgotinib or adalimumab. And filgotinib and adalimumab look like, in fact, they responded almost identically. This slide looks at the same group, the same study, and what it's looking at are the patient-reported outcomes, the activity instruments that we use, and you can see that basically filgotinib in the DAS28, which is an activity index, looks like it responds better to filgotinib at both the 100 and 200 milligram dosage, except at week 12 and 24, but at week 52 they kind of get quite similar. But the other activity indices that we use are about the same across the board. But the other point here is that the methotrexate group clearly doesn't respond as well. That's the gray bars at all the points. So basically, you have a choice here. It looks like in choosing filgotinib or adalimumab for these patients who are inadequate responders to methotrexate. Okay, this is in the same group of patients. So the methotrexate inadequate responders who were treated with filgotinib or adalimumab or placebo. And the change from baseline for the patient-reported outcomes looked at by SF36, filgotinib provided greater improvement in health-related quality of life versus placebo at week 4 and 12 for the SF36 and the mental component summary. And by week 4, patients receiving either dose of filgotinib reported greater FACIT-Fatigue scores versus placebo. That significance was maintained through week 24, and improvement in reported fatigue continued through week 52 in the filgotinib groups. So this is a different study where patients were randomized to filgotinib versus filgotinib plus methotrexate in methotrexate-naive patients. So this is using filgotinib right out the door rather than going through methotrexate first. And what you see here is on the left, the ACR scores, ACR 20, 50, and 70, the DAS28 CRP scores, and structural differences, right? So you can see that using filgotinib alone was really pretty equivalent to filgotinib plus methotrexate in the ACR responses, both 20, 50, and 70. And fairly similar, although a little discriminatory for DAS28 in favor of the combination, and that structural differences were different between the two, looking like filgotinib in combination with methotrexate responded better, but pretty significant. These are, in that study, the changes in patients' pain and fatigue at each visit. And you can see that through week 24, pain improved best in patients receiving the filgotinib versus methotrexate. Okay, we're going to turn to safety now. These are pooled clinical trial long-term data looking at all patients exposed in clinical trials to TOFA, Bari, UPA at a low dose, UPA at a higher dose, and all filgotinib in open label extension studies. And you can see here that infections, which are highlighted in the box, were quite similar from the perspective of serious treatment emergent adverse events across the board, with a suggestion that they were a little bit less in the Filgotinib alone group, the Filgotinib open label extension group, and perhaps a little higher in a higher dose of Upadacitinib. But if you take that away and look at UPA at its approved dosage, UPA is pretty similar to Bari and Tofa. Just a note on the Filgotinib, the number of patients studied were similar to UPA, but the length of study was actually less than for the other JAK inhibitors. The incident rates for herpes zoster were similar across the board, except for the UPA 30 group. But if you knock that out, then UPA, Bari, and Tofa are very similar. Again, Filgotinib is a little bit lower, but again, a lower period of observation. Malignancy incident rates were similar across the board, all pretty low, except for at the UPA high dose, but that's not what's approved. And deaths were very low and similar across the board. This slide looks at the incident rates of serious infections, looking at biologic DMARDs and tofacitinib rates in randomized controlled trials and long-term extension studies. And you can see that JAK inhibitors, Tofa, it was the only one that was really looked at, was really the lowest. And it was down there with rituximab, which we know is low because it doesn't affect plasma cells and therefore immunoglobulins as much, and also low like Abatacept, which we know in clinical practice is associated with fewer infections, and we usually go for those two, Abatacept or rituximab, if we're concerned about infections in patients. But it looks like JAK inhibitors, at least Tofa, is in that same category looking at this data. This slide looks at upadacitinib and integrated safety data from an infectious malignancy and deaths perspective. And these are looking at treatment emergent adverse events in a significant number of patient years in either upadacitinib group, the lower and the higher dose. So you can see that, and we'll just focus on the lower dose because that's what we use. The rates are comparable across the board though, so that's good. And they're relatively low. Malignancies are low. And the rates of non-melanemic skin cancer in UPA 15 or similar to adalimumab, with numerically higher rates on the higher dose of upadacitinib, but again, that's not relevant. And deaths in patients exposed to UPA are not higher than that expected from the general population. So that's all very encouraging. This slide looks at UPA versus Abatacept in terms of treatment emergent adverse events. And you can see that they're quite similar, except for some increase in transaminases in the UPA 15 milligram dosage. And I'm not sure whether that pans out in clinical practice quite yet, and I don't know if it's really all that significant, but something to be aware of. This looks at Baricitinib integrated safety data, looking at serious infections by age group. And you can see that while the serious infection rate is similar to placebo in younger patients using Bari at a high dose, higher than approved, and all Bari RA exposures, it was higher in patients who were older. So something to be aware of. But interestingly, in that older population, the incidence rates were actually higher in the placebo versus in the Bari groups. This is looking at Filgotinib safety, and here we're looking at serious infections, zoster infections specifically, DVT and PEs, deaths, malignancy excluding non-melanemic skin cancers, and major adverse cardiovascular events. And you can see we're here looking at placebo plus methotrexate or other conventional synthetic DMARDs, adalimumab plus methotrexate, filgotinib at a low dose plus methotrexate or another conventional synthetic, higher dose filgotinib, higher dose alone, and the total filgotinib exposures. And you can see that serious infections are really similar across the board, perhaps lower with the filgotinib groups compared to adalimumab. Zoster is low and similar. DVTs were very low and similar. Deaths low, similar. Same with malignancy and major adverse cardiovascular events. These are integrated safety data for filgotinib, looking at treatment emergent adverse events across all treatment groups, looking at adalimumab patients versus methotrexate alone. Well, these are on the right. We have filgotinib at 2 different doses compared to adalimumab and methotrexate. And in the methotrexate controlled group, we're looking at well, in the adalimumab group, the first panel is adalimumab as a control. Second group, methotrexate is a control. And basically, you see that exposure-adjusted incidence rates of serious adverse events and treatment-emergent adverse events leading to death in patients receiving filgotinib were comparable to those for placebo, adalimumab, or methotrexate, with no dose-dependent effects seen. So that's all very encouraging as well. This slide is looking at the risk of Zoster in treated RA patients, looking at it from a multivariate analysis with inverse probability weighting. And you can see here that there are several factors that confer some increased risk, which is increasing age per 10-year blocks, the use of corticosteroids, 10 milligrams versus 0, the use of monoclonal TNF antibodies, T-cell co-stimulatory modulators, but JAK inhibitors was really one of the highest in the study. So we need to look at that a little bit more. So what I did was I looked at there's a German biologic registry called RABBIT, and it was done to analyze the comparative incident rates of Zoster and RA patients under treatment with different modes of action, and potential risk factors were then compared. And what they did was they calculated crude incident rates of Zoster per 1,000 patient years, and probability weighting was applied to adjust for confounding factors. They had data on over 12,000 patients, which constituted 53,000 plus patient years of observations. And in that, a total of 452 Zoster cases in 433 patients were reported, which 52 events were serious. And what they found here was the crude incident rates compared to all the different other possibilities for methotrexate inadequate responders was definitely higher in JAK inhibitors. So what are for JAK inhibitors the risk of Zoster? Well, looking at the different molecules. So from this study by Kevin Winthrop in Oregon, he looked at patients with RA treated with the different types of JAK inhibitors, and he saw that there was a 1.5 to 2-fold higher risk compared with similarly aged individuals in the general population as a starter. And the RA population on biologics, the risk was 2 in 100, whereas the RA population on JAK inhibitors was 3 to 4 in 100. So based on that finding, the ACR guideline recommended that patients greater than 50 years of age with RA should be vaccinated before receiving biologics or tofacitinib therapy. This was obviously then extended when the others came out because of the data that you've seen. But that's not really a problem in clinical practice because we have Shingrix now, and so we recommend that all patients at least receive their first dosage before starting on a JAK inhibitor. All right, focusing now on thrombosis and pulmonary embolism. So from a federal reporting in February of 2019, TOFA had been associated with 45 patients with PEs and 19 with pulmonary thrombosis. There were increases in thromboembolism and PE reported for Bari and TOFA, and RUFA, which is not available here in the US. And TOFA, as a result of these reportings, at 10 milligrams BID, that dosage was dropped from phase 4 studies, and Bari was approved only at the lower dose. The incident rates was greater than 0.4 for TOFA and less than 0.1 for the TNF inhibitors. So this all led to a box warning for the 3 FDA-approved JAK inhibitors indicated for RA. These data show the results of a disproportionality analysis comparing the rates at which an event occurs with a drug with the rate that it occurs without the drug. You can see that TOFA in the US was really associated with PE, not so much DVT, but in Europe, it was associated with both DVTs and PEs. And Bari in Europe was associated with both DVTs and PEs at a high rate. So those are things we need to keep in mind. These are integrated safety data from Bari looking at DVTs and PEs over time. And you can see that the incident rates per 100 patient years of exposure overall is 0.5, and that 0.5 is maintained over 240 weeks. This is the VTE incident rates in RA patients from observational databases, and you can see that the crude incident rates per 100 patient years is really actually highest for conventional synthetic DMARDs, but they remain high for all of them. And TOFA and TNF inhibitors are actually are quite similar, actually. But it's an interesting finding. So what's my summary statement for these confusing data, Zoster and DVTs? Well, Zoster in RA is a common occurrence. JAK inhibitors are associated with significantly higher risk of Zoster. Several biologic DMARD classes also observed to have a high risk of herpes zoster. In terms of thromboembolic safety of JAK inhibitors, we should restrict the use in high-risk patients, and more studies are needed as a class effect can't be ruled out. And in considering mono versus combination JAK inhibitor therapy, both approaches have a role in RA management, and the treatment decision should be individualized for the patient. And you need to consider these zoster and thromboembolic risks. Turning to lipid abnormalities with JAK inhibitors, this slide is meant to show what happens with serum HDL and serum LDL. And you can see here that they both go up. And so it's not just a non-protective, but it's also a protective increase in lipids. But this is something that we need to keep in mind as we approach our patients. And note here that the serum LDL in IL-6 receptor blockade is much more disproportionately increased compared to HDL. It's not necessarily all that much more increased for LDL compared to Bari and TOFA, but there's a real disproportionality here between LDL and HDL. Let's talk about pregnancy outcomes. There are some insights that have been gleaned by Megan Close in North Carolina. We know from her studies that TOFA has the potential to cross the placenta. There are a reduced number of viable animal fetuses and fetal body weight with tofacitinib doses much, much higher than the human dose of 5 milligrams BID. There are 47 cases of pregnancy in patients exposed to TOFA during clinical trials, with most of them being in RA, but some in psoriasis. And those outcomes led to healthy newborns in over 50% of the patients. 15% were associated with spontaneous abortions, which is less than the normal patient population of spontaneous abortions, which is 20%, and congenital abnormalities in 2%. But pregnancy planning and prevention should be considered for females of reproductive potential. So in summary, JAK inhibitors are clinically, functionally, and radiographically effective in RA, both in combination with conventional DMARDs in conventional synthetic DMARD resistant patients. They're effective as monotherapy, effective after conventional synthetics prior to a biologic, at least comparable to a TNF inhibitor, and after failure of a TNF inhibitor. There are really, though, currently no head-to-head studies among or between the different JAKs, and data are needed to further evaluate switching from one JAK inhibitor to another in non-responders. Starting a JAK inhibitor before a biologic DMARD in a conventional synthetic DMARD incomplete responder may be reasonable, given data suggesting that JAK inhibitors are at least comparable or superior to a biologic. Can we use JAK inhibitors as monotherapy? Well, approved JAK inhibitors may be used as monotherapy or in combination with methotrexate or other non-biologic DMARDs. Data has demonstrated effective use of JAK inhibitors as monotherapy. Currently, patients are often already on methotrexate, though, so JAK inhibitors are typically just added on. One study concluded that patients who achieve low disease activity with a combination of tofacitinib plus methotrexate may consider withdrawing methotrexate without significant worsening or disease activity, and that's shown here on the right. So, searching for the right drug in methotrexate inadequate responder population, JAK inhibitors have superior clinical, functional, and structural improvements compared with methotrexate and methotrexate-naive RA patients. JAK inhibitor therapy could conceivably be used as a first line if costs were equal, but methotrexate could be effective and is less costly at that point. But in methotrexate inadequate responders, JAK inhibitors are at least as effective as adalimumab in head-to-head trials. So it's reasonable to use JAK inhibitors ahead of biologics if access is equal. UPA and TOFA have labeled indications for use in methotrexate inadequate responders. So it's really up to you after considering your patient. So JAK inhibitors, just to summarize, are a major addition to the therapeutic armamentarium. They represent a new approach to the treatment of patients with RA. They provide the convenience of a single oral tablet. They have demonstrated safety and efficacy in a number of trials, but one size doesn't fit all. Having different mechanisms of action and a variety of agent allows for individualized treatment for patients. Okay, the first question is, what is the incidence of adverse effects with combining methotrexate with JAK inhibitors? Is there a concern for increased liver toxicity? So that hasn't been seen in the observational studies, but I think it's something that we need to be aware of moving forward. With methotrexate, we monitor patients at 3 months per ACR guidelines. So we'll see what happens. If you get into trouble, go ahead and treat accordingly. Do you recommend adding JAKs to methotrexate or stopping methotrexate and starting JAKs for inadequate responders to methotrexate? It really depends on the patient. If you just need a little boost versus you really have no response, I think that really drives my thinking. Right now, I have been, if there's really no adverse events to methotrexate, just not enough effect, I'll just add a JAK. But if there's some concern for some intolerance to methotrexate, depending on what it is, I may just stop and move to JAKs alone. Do you recommend a coagulation workup prior to starting a JAK inhibitor? If so, what type of workup? Would you also recommend low-dose anticoagulation in a high-risk patient? Okay, so this is a complicated question, multifaceted question, and I don't know that we have the right answers. I think that if you think that somebody's high risk, you may want to avoid JAK inhibitors and move to something else. Presumably, if the patient is high risk, you have already done the appropriate workup looking at antiphospholipid antibodies and lupus anticoagulant. So you'll know that. Would I recommend a low-dose anticoagulation in high-risk patients? No, I would really use probably something different other than a JAK inhibitor. Okay, next, you guys are full of good questions. What is the efficacy of Zoster vaccine in patients on JAK inhibitors? Has it been compared to efficacy when vaccine given with TNF inhibitors? No, we don't have that data yet, but that's being done right now. So hopefully soon we'll have that data. But right now, what I'm doing is if I'm choosing a JAK inhibitor, I'm definitely giving the patient Shingrix, and I'm doing that routinely. Next, what about adding JAKs to biologics like anti-TNF inhibitors? Good question. There's no data on that really, and I haven't done that. I use basically them alone rather than or with methotrexate, but I don't use combined therapies. We don't have any data, and I imagine safety may be the big concern here. So we need to actually get some data on that, if anyone's bold enough to do that. Excellent question. So, okay, well, thank you very much for your attention. Take care, everyone. Be safe.